Welcome to the session. In this session, a panel of thought leaders will share proven best practices for cultivating a strong employee workforce, including tactics to address administrative burden, strategies for leveraging technology such as telemedicine, and insights about implementing innovative workplace models. Before we dive in, we'd like to thank the sponsors of this session, Intelligent Medical Objects, Synergy Health Partners, UKG, and Vizient. For more information about our sponsors, visit the conference microsite and the agenda booklet. Okay, hello everyone. Welcome to the session. I'm Maria Castellucci, a content strategist here at Modern Healthcare, and I'm thrilled today to be moderating this wonderful panel discussion with executives with a wide breadth of experience in technology, staffing, and change management. In this discussion, we're going to be talking about leadership and culture shaping healthcare in the future. Our speakers will be sharing best practices for cultivating a strong employee workforce, diving into shifts in care, how to leverage technology, and innovative workplace models. Before we dive in, I'd like to introduce our speakers. So first, Nan Finnis. She is the Chief Nurse Executive at UKG. At UKG, Finnis applies her strong foundational knowledge of the global healthcare system to advance the application of innovative technology to create more meaningful and connected work experiences for all healthcare employees. Thanks so much for being here, Nan, and I'm really looking forward to your insights.
Thank you.
And then next we have Brianna Motley. She's Principal of Intelligence for SG2, a Vizient company. Brianna is responsible for driving thought leadership and content development for SG2 and Vizient members on topics that span the system of care, including ambulatory strategy, digital health, and care at home. Thanks for being here, Brianna, and really looking forward to hearing from you.
Thanks, Maria.
And then also joining us is Ivana Namirad, Chief Operating Officer of Intelligent Medical Objects. Ivana joined IMO in 2012, where she now leads the company's software engineering, content development and delivery, project management, and enterprise IT departments. Ivana came to IMO with over 15 years of software engineering development and data experience. Really looking forward to hearing from you, Ivana.
Thank you.
And then finally, we have Dan Siegel, Chief Executive Officer of Synergy Health Partners. As the CEO of Synergy Health Partners, Dan is committed to the founding vision of designing innovative physician staffing and incentive programs that support hospitals and provide expanded patient access to quality surgical, anesthesia, emergency, and emerging hospital services. Excited to hear from you, Dan.
That was a mouthful. Thank you, Maria. Good to be here.
So like I mentioned at the beginning, each of you are really bringing a diverse perspective to this topic. So I'm really looking forward to hearing from your different insights. So I want to start with Brianna to kind of level set about where the healthcare industry is going to be in the future in terms of where and how care is delivered. So Brianna, can you start us off with that?
Yeah, I would love to. Thanks, Maria. One of the offerings SG2 has for the market is a future-focused forecast for healthcare utilization and how demand essentially is going to change as we look out over the next decade. And our most recent forecast actually projects relatively flat utilization in the inpatient setting, about 2% over the next decade. But there are two drivers of that. Number one is care shifting into the outpatient setting, which I know we've been talking about for quite a long time. But the second trend is rising acuity. And so patients that will be in the hospital are higher acuity, more complex, and going to be staying for longer lengths of time. I think our inpatient days forecast is actually 8% over the next decade. And so our hospital leaders will certainly be feeling that pressure as patients stay longer and longer in the hospital. On the outpatient side, though, there's a really interesting trend going on there as well. Definitely robust growth, but also what we refer to as a surgical shuffle. And that essentially means there's kind of a cascading effect. So demand in hospital outpatient, but also shifts from hospital outpatient to ambulatory surgical centers and to the physician office from a surgical services standpoint. So we'll see growth in all three of those settings. Hospital outpatient is 18% over the next decade. ASC, I think, is most robust at 25% over the next decade. And then surgical procedures that are happening in the physician clinic is also at 18%. So that's one factor. And then I think finally is this new phenomenon that's gaining attention with care shifting into the home. So we are seeing lower acuity medical procedures shifting into the home. again, as patients rise in complexity and acuity, that's kind of how demand is sort of level loading across the system of care. But as we look comprehensively, we know that all of the sites of care and integration more specifically across all of those sites of care is critical to effectively delivering care in the future.
Yeah, Brianna, that was really great and a really great explanation of how care is shifting and changing. Ivana, I would love to hear from you about what role data should play as we're seeing patients across these different settings. Can you kind of offer the data perspective?
Yeah, absolutely. So actually first, just a little bit about IMO because it's important context as I kind of give some of my answers throughout this. So we're a healthcare data enablement company, and we really focus on providing data quality both at the point of care and further downstream by enabling things like insights and analytics. So when we're talking about some of the themes around data today, one of the biggest ones is data quality. And there has been this tremendous increase in the vastness of data that is flowing into the hospitals today. And it was just 10 or 15 years ago that we were saying we don't have enough data. We need to figure out how to get the pipes to get that data to the hospitals and everywhere else throughout the healthcare ecosystem. And now there's just too much of it, and it is overwhelming. So we're seeing huge investments in people to try to clean that data, make it structured, standardized, consistent, as well as software solutions to try to create an actual consistent warehouse for all that data to live. And one of the areas that I think is really exciting is actually in the public health space, and that is the new director of the ONC that we have today, Mickey Tripathi, who deeply understands this data quality problem that we have. He has lived it throughout his career and is already making some strides in this area. One of the examples of this was, and something that I just learned about a month ago, that during the pandemic, the way that hospitals reported COVID cases was a spreadsheet was emailed to them. They filled out the number of cases for the week and emailed it back. That was how cases were reported. And I probably don't have to explain why that's a problem, but that is a huge problem. And one of the things that Mickey has already done is created a centralized electronic case reporting mechanism where not only will hospitals report the number of cases, but a bunch of other useful tangential data like lab results, like medications, overall how the patient was treated within the hospital will be monitored so that we can actually do better analytics and cohorting across pandemic. And we're already seeing the results of that through the monkeypox issue that's arose more recently. One other area other than data quality that I think is worth mentioning is the refocus on consumer data. So the ability to surface data for the patient. So Brianna talked a little bit about, the patient getting more involved in their care. I would definitely see there being a focus on patient portals and giving patients the ability to have better transparency, both into their care as well as billing. And IMO is deeply involved in this in a number of different initiatives, but we see this through our EHR vendors and other technology partners that we have today.
That's great. Thank you, Ivana. Thank you so much for sharing that consumer perspective. So, Nan, I want to dig into the workforce. So can you share your insights on what's going on with the healthcare workforce right now? And I know you also even have some stats and research in this area that you can share.
Sure. And I think there's a couple of points during the next hour or so where we'll get into some of this data more deeply. But just at a high level, I think it's important to set the context that, as we all know, healthcare, or we may not know, but healthcare is the biggest industry or the largest industry in our US economy today. So over $4 trillion of spending. Obviously, we're getting a lot of attention. That's the good and the bad news. The bad news, as Ivana spoke so eloquently about, is we see repeatedly exercises in Excel spreadsheets and manual work on paper and pen, even though perhaps the technology is sitting there capable of producing the data that is needed. So we're not using our technology or our processes very efficiently. But nonetheless, I just had to make a comment about that, just to give you a sense about UKG and some of the data that we collect. We have available, and we're supporting you with this link, but it's publicly available, what we call a workforce activity report. This analyzes weekly employee shift work and those trends across 35,000 US businesses and 4 million employees. So we look at this index on a monthly basis. It's available to all of you monthly, but it gives UKG and all of the industries really directional insight into the health of the frontline working economy across all industries. And I'll talk a little bit about healthcare. So just, kind of thinking about pre-pandemic to post, the healthcare sector as it stands today is working, and this is as of August. The report is coming out right in advance of the National Employee Report on Friday. But 90% of the shift volume that we saw pre-pandemic has been recovered. So this is really looking at, and we want to say blue collar, but frontline workers as well have not recovered fully pre to post pandemic here. The workforce activity within the healthcare sector has declined 20 over the last 24 months. So what we're really looking at, this is a broad indicator that the labor shortage has hit healthcare harder than any other blue collar sector. And probably this team is well aware that that significantly has most significantly impacted the post-acute and non-acute workforce settings. So over the last few months, we're seeing that there's been a couple of early indicators that we say are hopeful. The job market seems to be loosening up a little bit. Healthcare workforce activity trends are getting a little closer to that pre-pandemic, actually to a flat model each month. And they're starting to outperform other sectors such as manufacturing and service sectors. So even though we saw a slight decline in workforce activity nationally in August, there is hints that job growth is just slightly behind last month's numbers. And our team, who analyze this data on a monthly basis, are really calling this a soft landing for the job market when the next government report I share will be out on Friday. So relatively good news, overall, and we're watching this, very pointedly month to month and week to week. So just wanted to give that context, Maria, before we began.
Yeah, so Nan, you offered really great perspective on what's going on with the frontline worker. Dan, I would love to follow up with you here to talk about the surgeon workforce challenges right now.
Okay.
Can you talk about what you're seeing, Dan?
Yeah. Happy to. Absolutely.
Thanks, Dan.
Nan, thanks. Yeah, I know we have very similar names, so Nan and Dan. We'll get it sorted. Yeah, absolutely. No, I appreciate. I mean, sort of similar perspective from surgeons, but maybe a little different. I might take a quick step back to some of the stuff Brianna talked about in terms of kind of the shift of care, sort of the where it's going and how it's shifting. Talk a little bit about some of the macro trends that we're seeing specifically as it relates to surgeons. Then I can talk about some of the challenges in the workforce. So I think everyone agrees there's an aging patient population. So with respect in particular to orthopedic surgery, a lot more falls, hip fractures, broken bones. So there's going to be a lot more of a need for orthopedics in the coming years. In fact, they're predicting about 5,000 orthopedic surgeons short relative to the actual need. And for hospitals, that's a big deal because each orthopedic surgeon brings about $3.3 million in revenue, which includes the actual care itself, the surgery itself, plus all the downstream associated revenue, radiology, et cetera. So we're also seeing falling reimbursements in a general sense, which is combined with increase in staff compensation. It's creating a lot of compression on margins for hospitals, which is certainly challenging. A big factor, Maria, that I know we're going to talk more about is just this concept of clinician burnout. Mm-hmm. And so, you've got a lot of things happening where clinicians are, exhausted from administrative fatigue. But younger surgeons in particular are also seeking more work-life balance in their lives. So it's, I think, just a general trend. They're not gunning to be in the hospital every minute of every day any longer. They want to, work hard and then also have time with their family and to pursue their passions. Some of the interesting things too, there seems to be more use of advanced practice folks to help out. So PAs for orthopedic surgeons that can kind of help, get the surgery set up and close the patient and do some of the follow-up care. So it can help extend care, which is great. And then of course, I know we're going to get into kind of advances in technology that really allow us to extend care. A couple other quick things. It seems like, as care shifts towards less acute settings, patients generally tend to prefer this. I don't know, Nan, if you're seeing that as well, but it's a more relaxed setting. Sometimes hospitals can be a bit intimidating and, for most patients. And of course, there's cost concerns, right? You're able to bring the cost down as well. And then one other trend we're seeing is that hospital administrators seem to be more open to creative care partnerships. So as opposed to having to employ everybody in the facility themselves, there are ways that niche staffing companies can kind of come in and help fill the gaps, especially for us in the on-call panel in the emergency departments, where it could be challenging for them to cover everything that they need to. So real quick on our model, Synergy in short, it's very similar to what the hospitalist model was or is, right? So providing that very specific hospital-based care, but for surgery. So we staff mostly general surgery and orthopedic surgery to help fill the call gaps at acute care centers, and particularly in rural areas where it's increasingly difficult to find folks to staff, and they're closing at an alarming rate. Synergy has created the surgicalist model, which can allow surgeons a better quality of life. So effectively, they show up for 10 days a month, and then it's supplemented with 3 surgeons at a particular site. So that creates this complete care coverage. Then they get 20 days to be home with their family. We have surgeons that climb Mount Everest and do mission trips to Honduras and actually get to have dinner with their spouse, which is a novel concept these days for clinicians. So it's really about work-life balance for the clinicians so that the hospital clinicians can also have a rest. So we take all the call panel on their behalf and allow those local physicians, those local surgeons to actually get a break as well and be able to show up rested for the work they're doing as well. So yeah, that's just a quick overview of what we do and kind of where we see the market headed. In terms of the specifics on the healthcare workforce, one other thing I think that a lot of surgeons are challenged with is care conflict. So if you have elective surgeries and you've got a list of patients you're going to operate on the next day, you get called in for call, you have to cancel those cases. So they can't be in 2 places at once. So that's another real added value that we can bring to physician practices, which is to have dedicated call coverage so that they can focus on their elective work.
Yeah. Well, thank you all for really setting that picture from a clinician perspective, data, and then a care shifting perspective too, and how care is shifting. So I want to dig a little deeper into best practices. So what are some of the most innovative staffing and resource plans that are in place right now and they're successful that should continue to be applied going forward? Nan, can I start with you?
Sure. So I would say there's so much, first off, so much innovation occurring in the industry. It's really exciting to see. I think this is based on a couple of things that are happening. One is I think we as an industry are stepping back to and needing to step back to look at the foundation of our operations. Where is there waste? How can workflow and business processes happen more effectively and efficiently? Our leaders are really thinking about the future. They know, and we all know, and certainly UKG is our mission is people, and so we touch all aspects of people in healthcare organizations and across all industries. But we know that competencies of leaders are changing and will continue to change, focusing more on creativity, coaching, entrepreneurial visions, and obviously change management as we all kind of face this period of time. For the first time, and I think, Dan, to your point, this is the first time in decades in the acute care setting, patients' level of satisfaction has decreased. So we know that to be innovative and successful in the future, as you asked, Maria, we have to be patient-centric in our delivery. That patient consumer experience is going to drive all of our innovation. And I heard earlier mention patient acuity that, and I know that has been continuing to increase over the last several years and also into 2022, where we look at average length of stay increasing about 10% year after year. We know also some data that's, obviously very compelling as we think about this workforce and innovation strategy. 22% of nurses, when we look at it was about 400 frontline nurses last year, but 22% of those nurses across the country were considering leaving their current position within the next year. But even before the pandemic, and I think this is the same for physicians as nurses, but 1 in 5 nurses left the job within a year, and some left our profession entirely. And I think that number was probably 1 in 3 for physicians. So we've had these issues for a long period of time, and we really need to, be sure that our innovation is sort of raising up these issues and providing solutions to them. We know that research has proven that optimizing staffing is integral to not only a high level of patient care, better family patient experience, but also nurse well-being. So, we have to kind of think of how how these structures are put into place that truly optimize the individuals and the resources that are placed in that work setting. Digital engagement with patients and communities has increased. We all know that. I think we'll be able to speak to that very well. But we know now, after much experience during COVID, that healthcare can be delivered remotely, can be delivered successfully remotely. And that offers not only greater flexibility for patients, providers, but also for staff. And we're seeing some innovation around coaching of staff and visibility of staff on virtual platforms to really be there to support newer staff in the workplace. So a lot of technology innovation that's happening when you think about staffing and workforce. And employees of today and tomorrow, I may say, are looking for connection. They're looking for meaning and purpose in their work. They want that 10 days on and 20 days with family and life. And so whatever we do sort of innovatively, and we're seeing this today, it's about well-being and really crucial work-life balance. So just a couple of things that I thought I'd start with, and I can add to that, Maria, as you see fit.
Thank you, Nan. So Dan, follow-up, do you have any follow-up here to talk a little bit more about the physician perspective on this?
Yeah, I mean, I thought it'd be helpful to share just a really quick case study. I mean, I talked about the challenges with rural hospitals in particular. And, it's interesting as, I've been in the role for about a year and have seen a lot of different types of challenges that hospitals are facing out there. But I think rural hospitals, critical access hospitals have a unique challenge. Sometimes it's hard to get the right physician to move to a rural area. They might have family already embedded in school or their spouse has work. And so, the work opportunities to bring a spouse in and also find a job in a rural area are generally more challenged than a suburban or an urban area. So that's where our model works particularly well. Is, we've got a critical access hospital that was setting up a new orthopedic program, for example, and they for about a year, they had a really hard time staffing it. When they found out about our model and called us, we collaborated with them to understand exactly what their needs were, the type of cases that they were needing to cover. The patients in that community were having to travel sometimes 30 minutes to 45 minutes to deal with any of their orthopedic needs. So we came in collectively, put this program together for them. Because the surgeons didn't have to move there full time, they were able to come in for those 10 days and then go back and be at home with their families wherever they live. It provided a symbiotic situation where it worked out well for everybody. The surgeons have now been enrolled for several years now. They're not, to be clear, it's not like a locum situation, which I know can be necessary sometimes to plug a short-term gap. But it's locums can be a more expensive model, and it's a more transient model. What we do is place folks on a more permanent basis, so they actually become part of the care continuum at the facility, and that's their facility every time they work. Those 10 days a month, they're back at the same place, so they get to understand the workflow, the patient needs, the hospital needs, the transfer of patients. And that program generated 40% increase in volume for that particular hospital, which again, from a rural hospital's perspective, those keeping those dollars and that downstream revenue in the community is critical, not to mention the benefit to the patients of not having to travel, 30 or 45 minutes every time they need to see their orthopedist. So yeah, we're excited about continuing to be able to bring this model out to more and more facilities.
Yeah, it's great. I love the flexibility that you're providing for physicians and surgeons. It's great. So I want to dive into technology. You all have been mentioning technology, and it's growing importance. So, we know that that tech solutions, the EHR, telemedicine, they're going to continue to play a role in healthcare in the future. So Ivana, can you share a bit about the clinician experience with the EHR as it relates to burnout? I know we hear a lot about that. What can hospital leaders do to improve the clinician experience with that? And what kind of practices can they put in place?
Sure. I think one of the key things we have to remember is that EHRs were initially created to facilitate revenue cycle management, right? So they were platforms to take in data to facilitate billing. Now they've evolved significantly over the past 3 or 4 decades, and actually IMO itself was founded to help facilitate the provider workflow within the EHR by giving them medical terminology that allowed them to capture data in the way that they intended. But the reality is we're not where we need to be yet, and technology is very much a part of the provider burnout problem. So a few key themes that we're seeing today is one around the fact that we force providers to document multiple times. So a few examples of this. One is, for example, visit diagnosis severity. It doesn't automatically populate the problem list. So whether or not the provider notices that at the point of care, he or she will have to document a second time within the problem list. Or if they don't notice that, then it causes frustration and potentially identification issues later on. The prior auth workflow. So they'll order a procedure within the EHR, but then the doc is forced to go into the third-party auth platform to re-identify the diagnosis and procedure. There's a bunch of other examples like medication management, allergen checks and rechecks, drug-to-drug interaction, supply chain availability. It is a chaotic environment for the provider to have to remember all these things and document multiple times. So that's one key theme we're seeing. Another one is alerting burnout. So within the EHR, there are a number of embedded EHR workflow alerts that pop up, but also there's a number of third-party systems that many hospitals are investing in that embed directly within the EHR through a Smart on Fire interface that will alert. So providers are getting multiple alerts all the time. They don't know what's necessarily important and what isn't. So they end up closing most of them. So multiple clicks to just kind of ignore them. But the reality is they're probably ignoring some really important alerts and messages in that. So again, causing burnout, causing frustration and concern. So I would say from a healthcare executive or leadership perspective, some things that I think are important is to be a champion for your providers, to really sit down, shadow them, and understand their workflow inherently, really live it with them, and figure out where the biggest pain points are. And then strategically make investments that help to address some of those things and define metrics around how you're going to optimize those workflows. And when you do contract with third-party vendors, or even when you're working with the EHRs directly, hold them accountable to improvement of those metrics over time. And then with your staff, I would say too, is another big part of this burnout problem is the fact that they constantly feel like they're in technology training sessions every other week because of some new feature that's popping up in the EHR. The reality is if you share this broader optimization strategy with the team, they'll have a better feel for the fact that you're trying to make their experience better, and they should hold you accountable to the same types of things that you would hold your vendors accountable to.
Hey, Ivana, can I ask you a quick question?
Sure.
I think it's super interesting that I did not realize that EHRs were originally created for revenue cycle management. And I wonder if clinicians know that or really understand that. I mean, when I talk to some of our orthopedic surgeons around some of the challenges that they're facing with the administration and the EHR in particular, really two themes come up, and I'm just curious sort of what your thoughts are. One is this promise of interoperability has not yet been fulfilled, right? You've got more of these silos between kind of the various mega providers, and so maybe they're not getting the information they need as quickly, or access may be difficult. And the other is, I don't know that they knew that a lot of the data entry was going to fall on their shoulders, and so they're spending an inordinate amount of time. You've got the highest paid, workers in the hospital doing a lot of data entry. Some say like 15 hours a week. So their thought is, well, couldn't we hire scribes to help us input the data? Couldn't we be involved in the decision on how implementation happens, and even on sort of the development of the EHR platforms? Like they sort of feel left out of the conversation. So I'm just curious if you have thoughts to share on that.
I do. So interoperability, there are some really strong pipes in place to get data from one system to the other. But back to my data quality theme that I keep harping on, it is inconsistently being referenced in the interoperability standards. So even when data gets from one system to another, it's in a completely different format and not usable until someone goes, cleans it up, and likely has to do the legwork to talk to the prior provider to really understand what was actually documented. So agreed that interoperability isn't completely there yet, and I know that there's a lot of activity happening around evolving that. I would say on the EHR front, the data entry front, one of the things that, because we partner very closely with all of the major EHRs, our software is embedded in all of them, is that there are forms where not all fields are required. And yet providers feel like they have to fill every piece of data in those fields. And so I do think it's important for healthcare, the hospital leadership, to figure out how to partner with the EHRs to make some of those forms more useful, and figure out what's actually necessary for these providers to do their jobs. And I would say partner with the EHR vendors. All of them are very much customer centric, and they want to make the experience for their customers better. I don't think it's woe is me kind of a situation. I honestly think there's potential to improve this in whatever way the hospital sees fit.
Great, thanks.
Yeah, thank you for that question, Dan. That was really great insights, Ivana, and really great real world practices that leaders can put in place. So Ivana, it's because this is the Hospital of the Future virtual briefing, I wanted to ask you a more forward-looking question. How do you expect clinicians' interactions and experience with the EHR to evolve and expand in the future that our audience should be aware of?
Yeah. So just kind of playing on the last question, I would say you should expect to see continued workflow improvement, both from the EHR vendors, but also these third-party interface layers that I mentioned are connecting to the EHRs through Smart on Fire interfaces. And we're one of them. So you should expect to see that those will all evolve. The other area is around harnessing the vastness of that data that's coming in. And one of the areas we're seeing that play out is in precision medicine. So that's gaining traction in a big way with many of our major EHR partners, especially around pharmacogenomics. So understanding the role of the patient's genome in a drug response. So prompting, for example, a provider at the point of care when they're ordering a prescription where there's a potential a relevant genomic data point. The other area is around patient cohorting and surfacing some analytics also at the point of care. So telling a provider, for example, hey, this particular patient's profile looks a lot like this other patient's profile within the hospital system, but even more globally. You're seeing some of these EHR vendors provide universal data warehousing across all of their organizations. I think that will be really useful and interesting. The other one is around social determinants of health. And you're starting to see providers really actively starting to capture this data and making it a huge part of the patient's care plan and overall understanding of the patient's needs. So high level, I think if we can really make use of the vastness of that data, there's some really cool things that can be done to make the provider's interaction with the patient more effective and efficient.
Great. Thank you, Ivana. So I want to switch gears a little bit and talk about how we're looking to expand digital health capabilities, virtual capabilities. What considerations should leaders make to determine those optimal staffing models as we're expanding to different care settings, virtual care settings, and then so much of digital is coming into the fold? Brianna, can you offer some insights on that?
Yeah, I can. And I think a lot of it stems back to some of the things that Nan and Ivana have already mentioned. But, first and foremost is really defining what you're trying to achieve. So what are you trying to accomplish with putting digital solutions in place and keeping that front and center? So I think the worst thing that we see is when systems put digital solutions in place and either they fail or they contribute to provider burnout, provider workforce, nursing workforce burnout because of all the alerts or because that Ivana mentioned, or because they make the day-to-day work more complicated. So really trying to kind of understand, what are you trying to achieve? What are you trying to accomplish? Are you truly making things more efficient for the workforce is front and center? And then the next thing that we kind of move to is, where are you today? So where are your strengths? Where are your gaps in line with the solutions that you're trying to put in place? And spending time, as Ivana mentioned, living that provider's day-to-day life, understanding their workflow before you even dive into, okay, here's the solution that we think makes sense to adopt to help address this challenge or this problem. And I think, there are, from a staffing standpoint, a lot of solutions out there that, if put in place in the right manner, can help address that. And I think Nan mentioned that already with virtual nursing in terms of supporting newer nursing staff, for example, who are at the bedside, and providing them that coaching and support to enable them and empower them to feel good about how they do their work. There's also, virtual triage solutions that work up front and from an optimization standpoint, kind of help to match the patient to whether it be sites of care or services where there is available staff. So trying to solve for some of those access challenges and capacity challenges that we know exist, especially in the low acuity setting. And, certainly, I think Nan also mentioned shortages in post-acute workforce. There is a lot of interest in remote monitoring right now, but putting that in place in a way that you're able to kind of centralize the monitoring of things. That, number one, provides kind of an opportunity for staff who maybe are burned out of being at the bedside. Here's a different way to deploy your clinical skills and capabilities, but also making sure that, to the point that Ivana mentioned, it's not just constant alerts that you get desensitized to and then start to ignore, right? You only get the alerts that really matter when it comes to needing to intervene. So I think kind of triangulating sort of all of these elements helps to inform how do you really optimize staffing as you deploy these solutions.
Thank you. Nan, I would love to hear the nursing perspective from you on this, and kind of what Brianna was saying, if you could kind of build off that, but from the nursing perspective.
Sure. Boy, there's so much to talk about here. So just a couple of points, and Brianna, thanks for your comments. Just to take off on a couple of them, it's a challenging period for all of us to make sure that we are using our precious resources the most efficiently and effectively. And maybe I'll move into a little bit of productivity discussion here, Maria, if that's okay. But we've been doing a lot of work looking at, staffing, and what is that appropriate staff? So let me just talk about that a little bit as so much more science and thought leadership is emerging in this space. There's, I think if you were to think about really nurse staffing, very similar background, Ivana, to the EMR genesis. This is nursing has been considered a cost. And it is, really been perceived as just a overhead room and board cost. Staffing has been traditionally done using a midnight census, and I hate to say it is still being done in that way in many of our acute care hospitals in the U.S. today. So you all know so well the surges of volume and acuity changes and all the things that happen on a individual unit. Well, we're still looking at a stagnant number and then staffing to that number. And this, we have to be thinking about nurse staffing as how do we maximize the investment? And I said earlier, this precious resource, how do we truly maximize that investment? So a lot is happening to really look at that value proposition. What are we doing to make sure that that value is being delivered directly to patients, to families, to the care teams that are professionally that we're supporting, and then obviously to the payers and providers themselves. So we're seeing a lot in that arena, and just a few things that I think I would mention. As far as productivity, clearly it's not just the number or the staffing ratio, although organizations continue to monitor and measure productivity using some of those raw numbers. That's fine. But again, if you're thinking more of the investment and the value proposition, we should be looking at how does nurse staffing impact on patient outcomes, on care outcomes? And what is that measure of quality, safety, and finance? And even as we mentioned, social determinants of health. There are organizations already beginning to profile, and I don't, maybe that is not the appropriate term, but really to look at attributes of their patient populations using these social determinants of health. And then they're looking at, okay, so if you give this sort of complexity to a patient and you're looking to staff with that regard, what is the best staffing blend, mix, care team blend that will get to the best patient outcomes, knowing that this patient, for instance, is perhaps, has a history of poverty or has a food insecurity issue, or, so really tying those social determinants of health into day-to-day staffing so that we can look at, what's the most appropriate number and blend of staff. There's been studies that have been done today that leaders of particularly acute care facilities have no idea what competencies or skills are existent across their workforce. They've never been thinking about that. It's been about the numbers, but there's, as patient complexity changes, our workforce matching so that we have the right patient being cared for by the right team and the right individual is so very critical. UKG, I think everyone knows UKG, so I won't, really talk about it that broadly. But in our Kronos, we were Kronos and Ultimate Software. We merged our businesses 2.5 years ago and became UKG. But in both of those entities, the history of both companies has been, how do we really look at that workforce and all the skills, the competencies that they bring. And so we are really developing now a way to individually look at workers, look at the skills and competencies that they bring, make sure that we're scheduling and staffing them based on their own desires and recommendations. And obviously to make sure that their work-life balance is maintained, and providing great flexibility and adaptability to the staff, to the managers, so that they can, and their handheld mobile devices, really have a view of what their schedule is. They can shift swap, they can do all that, with very few entries and pushes on their mobile phones. But we're going to bring that work life to them. They're going to see who they're working with. The team members, they can identify team members that they like to work with that complement their skills. Managers can do the same. So, we're really looking at innovative ways to make sure that from a worker perspective, that we're going to be providing that value, that productivity, and then we have ways that we can serve up all of this data on employees to a healthcare organization. We create so much data on each employee and teams of employees. So you can look at this and then combine that workforce data with your own BI tools, looking at quality, safety, and finance. We have to be able to, put that picture together to find balance between numbers, ratios, and outcomes. And so that's kind of what we've been focusing on. I'm sure this will lead to a lot of discussion here, but that's kind of at a high level what we're focusing on at UKG.
Yeah.
Yeah.
Dan, do you have a follow-up? Yeah.
Oh, go ahead.
No, I was going to say, do you have a follow-up, Dan, to that?
Well, Nan hit on all the key points. I just reminded me of sort of a personal anecdote. Recently, I went to get routine blood work and was able to use the app from the clinic to schedule the appointment, to check in, to let them know I was there. I mean, it was literally within a minute of sitting down, I was called in. Which never happens typically. Usually, that same clinic I've had to wait over an hour. So this advent of technology really made my experience much better. I got the blood work literally the next day, was able to pass it along to my primary care provider. And so, I had a much better experience. And I think, from the clinic's perspective, to your point, they were optimizing the workforce. They didn't have a extra staff necessarily doing administrative duties that they didn't have to do. And our chief surgical officer, Rand, likes to say, let's get every provider practicing at the top of their licensure, right? I mean, it's not his quote, but he likes to say it a lot. So it really is about, how do we optimize the workforce and let folks who are trained in very skilled professions, do their best work.
Right. And can I just add one thing to that point, Dan and Maria? When we think about, what's happening in our healthcare organizations today, there's so many disparate systems. Dan, you're describing kind of a uniform, seamless approach, perhaps. And just an example that we see often is, as staff are being used to float, if you will, or work across different care settings, or even within one facility in different care environments. It used to, many organizations still perform this way, but when you think about that movement of staff, how do you track where they're working, when they're working, and then, thinking about the manager and the administrative burden that requires? The manager has to go back and reconcile time against a cost center, time to pay, and as we kind of look over the schedule, we have all of this movement of staff that has traditionally been done manually. And so when you think about all of that, we calculate about 6 steps between someone moving, being floated from one unit to another, and how it hits their time card. So, just another piece is that unified integration of technologies, now so disparate and so siloed in our organizations. But focusing on that integration and seamlessness, I think, is only going to add to the efficiency gained for our all levels of leadership and staff.
Yeah, I mean, as we see, if an ambulance is trying to figure out where's the best place to take this patient as well, they've got to look and see where there's availability and where you're matching, to your point, where you're matching the right clinician with, the way the patient is presenting, and rather than very expensive transfers or lost time, or because clinicians at one site might not be available. I think there's certainly a lot that can, a lot we can dream of that, in the sort of the hospital of the future and care of the future, that is emerging. It's happening, and you can feel the transformation. But I definitely sense there's frustration because we're not quite there yet, and everybody's like, but it should be easy. We've got all this great technology, and we know how to do this. So, yeah.
Well, thank you all so much for these wonderful insights. I wanted to close out with a final question because we're at the Hospital of the Future virtual briefing. I wanted to go around and ask all of you, what does the Hospital of the Future mean to you and your organization as you look to, healthcare of the future? What does it mean to you? What does it mean to your organization? Brianna, can we start with you?
Yeah, absolutely. And I think, Dan just kind of set the last question up really nicely. We've spent a lot of time, I think, at SGT Vizient thinking about the future. We've always been pretty future focused. And there are elements that align with some of the things Dan was just mentioning. So the incorporation of digital capabilities to be able to kind of match staffing and capacity to direct patients to the right sites of care that they need, that are matched to their acuity, and then, when appropriate, enabling that transition of the care to the home. I think patient experience is another big one. Dan, I loved your anecdotal example there, making sure that we're putting the patient first and truly kind of meeting their needs, especially as they are more in charge of their own consumer dollar at this point in time. They have more choices. There's disruption in the marketplace. And I think we all have to kind of rise to the occasion of putting them at the center and making sure that as we design our delivery systems, we're keeping that kind of front and center. Recognizing where demand is going to go, making sure that you are planning a footprint that has ease of access for patients, and it's not cumbersome, it's not disjointed. We're really able to kind of easily and seamlessly navigate the system and optimize it so that patients don't fall through the cracks. And then finally, I think bringing data back into the conversation, because we certainly have talked about that a lot. It's having that integrated for us at SGT Vizient, the integrated cost, quality, and market performance data that enables you to kind of be proactive about how you plan and how you match your delivery system and bring scale and efficiency to the delivery of care.
Thank you, Brianna. Ivana?
Sure. Yeah. So actually, my answer is pretty similar to where Brianna was going, but really looking at it in three different dimensions. One, again, from the patient experience perspective, really creating an environment that enables their critical involvement in their care delivery. That would be a huge part of it. The second dimension around provider experience, and Dan, I loved how you talked about leveraging providers at the top of their license. That's the goal, right? Is getting them to a place where they feel empowered to make critical decisions at the right time without a ton of overhead. And then the third dimension is around executive staff and administration and enabling them with transparent P&Ls. Nan, you touched on staffing performance, being able to look comprehensively at their patient populations and making big decisions in that way. It's really, in summary, the leveraging of the vastness of this data in a way that makes the entire hospital ecosystem hum. And to do this, it will require partnership across all of healthcare. So, and I feel much more confident in that because, as all of you know, healthcare typically moves at a snail's pace. But the reality is, with the pandemic, we saw some serious innovation and partnership happening. So it's possible. And that gives me hope and excitement about the change required for better delivery.
Great. Nan?
Sure. If the four of us had to kind of detail this out, I think we'd be very similar in our ideals of what the hospital of the future is, and not the bricks and mortars of the hospital, but the healthcare organization at large. Just a few things to add then. Employee expectations, as we've all talked about, are growing and extending, and employer capabilities really have to keep up with that shifting labor market. So, how do we attract talent, retain talent? How do you help in the future? How are our leaders really sharing information, making employees feel, at home in their organizations? And comfortable to work to the top of their ability. So what does that all look like? And then, how do we engage newcomers into our industry in a way that's mentoring, coaching, and so that they have the interest to continue to stay. And as we've all talked about, I think on the technology front is we see so much robust capability in all of our technologies out there, but the use and the utilization of that is not often optimized. So how do we help organizations, and if our future organization, to really think about technology, how it can add to the work efficiency, and also standardize work processes that perhaps don't require human interaction, that can be done perhaps in an automated fashion much more readily. Work-life balance. What does that look like? Are we, using shifts and hours and indicators to look at fatigue and other forms of work-life balance, and really meeting expectations for employees so that they do come to work with their full self and can contribute in a full way. Just two other things is, I think our frontline managers in healthcare need our support, need so much support. We need to provide to them, the tools, the data that they can actually take action on and not have to analyze and spend a lot of time on. So, how do we really work with our frontline managers in addition to all staff? But I think they're really at the crux of needing our significant attention going forward. And then equity, diversity, inclusion, and really thinking about all of those initiatives, not only matching what our communities appear like, and come into our organizations with as far as diversity, equity perspectives, but how are we staffing to complement that community, and how are we really bringing in diversity into our workforce? So that we are all richer because of the experience of diverse opinion, exchange of information, and really how do we measure that, monitor that going forward so that, we are all in a constant state of improvement. So that's kind of, sort of my added points to Brianna and Ivana. Thank you so much.
Thank you. And then Dan.
I guess the beauty of going last with this panel is all the good stuff has been said. So easy job here, I guess. No, yes to everything. Just again, coming, from sort of Synergy Health Partners perspective, Nan, you kind of mentioned the word equity. I mean, we really think of equity in many ways, but particularly in the form of access to care for everybody, making sure that, patients can get care at the local level, right? At the end of the day, it's really about having care in your backyard, in your neighborhood. So, we definitely see, even as, hospitals expand their technological capabilities, at the end of the day, they still have to serve that patient in a local setting, wherever it is. Interestingly, as care does move, non-acute care does move out of the hospital, there will be more competition for hospital to hire talent, surgical talent from ambulatory surgery centers and other venues. So a lot of local and regional facilities often have a hard time attracting talent on a national scale. They don't necessarily have large recruiting departments or large marketing departments. And so one of the things that we really try to do with our hospital partners is extend their reach to a national talent pool and be able to find folks who they otherwise wouldn't have been able to attract, again, who don't necessarily have to move to a new location. So I think to be able to broaden the reach of talent and find innovative, creative ways of allowing folks to live where they want, but work where they're needed will be super important going forward.
Well, wonderful. That brings us to the end of our time together. I really enjoyed our discussion. Dan, Ivana, Nan, and Brianna, it was very nice hearing from you all and getting your wonderful insights.
Thank you, Maria.
And to our sponsors, Intelligent Medical Objects, Synergy Health Partners, UKG, and Vizient, thank you so much for your support of this event. For more information about our sponsors, please check out the conference booklet and our microsite. To our audience, thanks for tuning in today, and please enjoy the rest of the event.